I'm focusing on the GI perspective, and I just, let me see, there we go. I put this simple slide up here to kind of differentiate peritoneal carcinomatosis and the treatment, focusing on that, whether it be systemic chemotherapy or cytoreductive surgical therapy, from where there may be a role for endoscopy and gastroenterology, and that's in differentiating malignant gastrointestinal obstruction with peritoneal carcinomatosis. And there's, it's a heterogeneous group. You may have patients who present with gastric cancer, pancreatic cancer. I'm just going from the top to the bottom here. Gastric cancer, pancreatic cancer with an obstruction at the level of their primary tumor, with some degree varying from mild, moderate to severe peritoneal carcinomatosis. And what can we offer them, and what endoscopically, and what are their outcomes, versus patients, and then patients with colon cancer as well, who might have a malignant colorectal obstruction with peritoneal carcinomatosis. And that group who have a primary tumor causing obstruction with carcinomatosis may vary from those who have a non-obstructed colorectal lesion and carcinomatosis that is obstructing some other area, whether it be in the small bowel or some other peritoneal metastatic lesion or area. So I think, it's important as we approach these patients to approach them from a multidisciplinary perspective with the help of the radiologists, surgeons, the oncologists, the dietitian, nutritionists, and looking kind of the options that are there, and different outcomes within them. We seem to have all had a similar theme, as there's a lot of retrospective data out there. Almost, as far as I know, all the data from GI is retrospective in regards to this, and comparisons to surgery or just general outcomes. And there is, the numbers are limited at any one site. So you get patients who may, that heterogeneity that I mentioned, with different primary tumor sites or different characteristics, are oftentimes lumped into one group. And so it becomes difficult to do a powerful subgroup analysis. But that being said, some of the factors to be considered by a multidisciplinary treatment group is I approach it, I think, what's the performance status of the patient? How severe is their carcinomatosis? What's their primary? What's their expected survival, and treatment options? And then a little bit later, I'll get into kind of more anatomic considerations, which is where the endoscopy kind of really focuses in on what's the location or site of the obstruction. Is that their primary tumor, or is it a metastatic lesion or a carcinomatosis lesion? What's the length of the obstruction? What's the degree and severity of the stenosis? And is it an intrinsic or extrinsic to the GI lumen? So going back to patient characteristics, I'm going to take a moment to look at some comparisons between surgical, endoscopic, or non-interventional forms of palliation for these situations, and who should be considered for each one. This is a study that, again, retrospective, that was looking at over 10 years of data from the Mayo Clinic. It was published last year, and this has been seen is very similar to other retrospective studies that we have, which is that in general, let me close my, in general, and it's part of I think there's a lot of selection bias that we see in this. Surgical patients, in other words, if they have some type of surgical resection or bypass of the malignant gastrointestinal obstruction, those patients tend to live longer and have a longer luminal patency. However, they tend to have a much better performance status and healthier baseline, because they're kind of selected as candidates for surgery. So oftentimes the patients that are taken to endoscopy are the patients who may have, um, a worse performance status, maybe potentially more advanced disease, and an anticipated survival that's less to begin with. So just putting that into context. But some of this is what was interesting is, and I don't have this in the slide, but I'm going to mention kind of how this compares to outcomes for patients without carcinomatosis. So the third row down is the technical success, and you'll see it's pretty similar between surgery and the luminal stenting group, at about mid 80%. And this is lower than patients who may have just a gastroduodenal obstruction alone or a colorectal obstruction alone, where it's going to be up just above 90%, mid 90% for technical success, mid 90 to 99%, fairly high technical success. And to distinguish that from the clinical success, and you'll see going from that third row down to the top row, the clinical success drops to the low 60%. And there is a statistical difference between that and the surgery group. Now, interestingly, in this study, what differentiated a clinical success was that you relieved the obstruction. However, technical success was that they, if they had a leak or other complication, it might have counted against it. So you actually had a lower technical success rate in the surgical group than the clinical success, where that wasn't really possible in the GI group, in the luminal stenting group, because what made a technical success is that you were basically able to bridge the stenosis with the stent, and then clinical success was based upon the symptoms that the symptoms of obstruction were resolved. So in summary, you'll see that basically the technical success rate for endoscopic treatment in these or palliation in these patients is a little bit lower, but still pretty high, a little bit lower than if they don't have carcinomatosis, but it's still pretty high. But there is a drop off in the actual clinical success. And that's for a number of reasons, which I'll get into, and the overall complexity of these patients who may have more advanced disease. If you look a little bit down, I'm going to make some other comments that basically again, like I had mentioned, the survival is significantly higher in the surgical group, and so the median survival time, for example, was 2 to 3 times longer, and the luminal patency was actually quite a bit longer. And again, that's I think a large part is a selection bias in the patients that are being referred to GI, and it I think goes to show the importance of really medical oncology, surgical oncology, and GI kind of all commenting on what they think. And I think we kind of then defer to the surgeons as to whether they think the patient may or may not be a surgical candidate. Let me go to the next slide. So this is just a graph showing that survival. Again, this is not at all a randomized study. It's very much got selection bias to it, showing that surgical patients have a longer survival. But, and this is important, I think why so many patients end up going for endoscopy is that the difference is a 10% complication rate in this study between class 2 and 3 complications, and 45 to 50% complication rate in surgery. And there was a significant difference in the length of the hospital stay from about 4 days in the endoscopy group to about 9 days in surgery. So the recovery is shorter, the delay in starting chemotherapy or continuing chemotherapy is much shorter with stenting. And if the patients have a lot of comorbid illness, then they may not obviously be a surgical candidate. So next, I'm going to move on to some of the factors that we think of as gastroenterologists and how we're going to approach these patients with obstruction. So location, I'm going to go over in the next few slides. Length, however, the longer the stricture, obviously the more difficulty and the higher, the lower technical success and the clinical success also drops off, and the patient's symptoms will actually be palliated even if we are able to bridge it. Sometimes we can deploy multiple stents to get across the stricture, but that correlates with a decreased clinical success. And again, there's a difference between intrinsic and extrinsic, where extrinsic stenoses also tend to have a lower clinical success rate and higher degree of difficulty with stenting. So really quickly going over the location, I wanted to kind of first focus on gastroduodenal outlet obstruction, whether that be, and that's focusing mainly on kind of the antrum pylorus all the way towards the distal duodenum. And as we approach the ligament of Treitz, there becomes increasing complexity, mainly due to the sharp angulation of the ligament of Treitz that a stent may not be able to really either be deployed across, or once it's deployed across, maintaining patency. However, those stenoses that are close to the pylorus or the gastric outlet, including D1 and D2, have a pretty probably the best technical and clinical success rate. Issues to think of that I'll get a little bit later is whether they have a high degree of small bowel involvement as well, which if you open that area, the stenosis, they may not have complete relief of their symptom because they have other areas where the carcinomatosis is either affecting the motility or the or actually causing multifocal obstruction. Next, the small bowel. This is kind of a rudimentary picture, but I like it for this purpose because it shows just how packed in and angulated the small bowel is. And I'm just briefly going to say that there's limited role for luminal intraoral stenting in the small bowel, that being, with the exception of the duodenum. So anywhere from beyond the ligament of Treitz to the ileocecal valve. The part of that reason is because it's just a more difficult area to reach. We could try a colonoscope, get past ligament of Treitz, but there's so much angulation within the small bowel that the stents either, even though you may get a wire across, the actual rigidity of the stent catheter doesn't pass over that angulation very well. Or if it does, with the deployment, there may be kinking or migration issues in the actual with the actual stent even after deployment. So they're actually quite poor outcomes with small bowel obstruction, almost to the point where it may not even really be, worth considering doing because it approaches 0% clinical success. And then somewhere around 60% is colonic obstructions. And it's pretty equal between right and left colon and rectosigmoid in these studies. Although there is some consideration in the right colon and how close you are to the IC valve in clinical success, and the flexures tend to be more difficult from a technical standpoint. And then the caveat with these locations is that a differentiation between whether it's the primary source of their malignancy versus a lesion that's extrinsic from carcinomatosis causing the stenosis. And that's one of the difficulties, I think, because there's not enough data within these studies to really do a good subgroup analysis to get enough power to really look at how much decreased efficacy there may be with the extrinsic involvement. So this, I kind of liked this. It was that same study from the Mayo Clinic, and they looked at this data. And again, even though the data that they had looked at in their kind of review and in their in the data of their own hospital is limited by the retrospective nature and numbers, they did come up with this algorithm, and it's focused just on malignant lower GI obstruction. And part of that reason is because they had quite good success at relieving upper GI obstructions, that they felt like endoscopy may be a pretty reasonable kind of first line approach to those patients. However, because the outcome, the clinical success rate for lower GI obstruction was not as uniformly high, this is kind of a way to kind of approach it. So looking specifically at patients who may be a candidate. So in other words, they aren't so sick that no procedure should be considered. And among those patients, defining what are the obstructive characteristics. and what are, do they have obstructive character, does their obstruction have characteristics that may be unfavorable for clinical stent success? And those factors that they found are one, a small bowel obstruction, two, multifocal sites of obstruction, three, a long segment of stenosis, especially those that needed more than one stent, and anatomical considerations including diverticulosis, and I'll add to that, angulation of the location of the stenosis. And in those patients, if they were potentially surgical candidates, that surgery should be considered in those. If they didn't have a lot of those factors, if they didn't have any of those factors, or potentially if they had one but were a poor surgical candidate, to then consider intraoral stenting. And just to finish, I'm going to go back to that data from the study, and I wanted to conclude that if you notice here, between the first row and the second row, they did have some additional benefit by repeating the procedure to try to increase. So if patients had technical success, this initial stent was deployed successfully, but their symptoms did not respond due to mal-deployment of the stent or other issues, there was some increase by either deploying another stent, whether it was increasing the length of the bridging or a stent within a stent. And so if you look at that last portion of that algorithm in patients who initially, failed, who initially were technically successful but did not have clinical success, to consider repeat intraoral stenting.